Chapter 11, Inflammation and Healing. The inflammatory response, something that we really need to get a good grasp of. So what is the inflammatory response and why does it happen? So everybody who is born a human has an inflammatory response. It is part of our immune response and it happens automatically. We don't need to tell it to do it, it just happens. So this response is triggered by any type of cell injury or death, and that can mean many different things. So it can be from an actual physical injury where we fall and get hurt. It can be a chemical agent like a burn. It can be an infectious agent like a virus, bacteria, a fungus, a parasite. It can be an autoimmune reaction, which we'll talk about in another chapter. Or it could be a cell injury event. So an example of this would be a myocardial infarction, stroke, deep vein thrombosis. All of these things involve obstruction of blood flow, which leads to ischemia, which is lack of oxygen, which leads to cell injury and death. So all of these things will cause a degree of inflammation. So for example, the myocardial infarction, so that is when one of the vessels in the heart becomes occluded enough where it starts to obstruct blood flow. So after that's all said and done, the heart will become inflamed in that area. We don't think of it like that because we don't see it from the outside, but there is an inflammatory response happening. The purpose of the inflammatory response is to do three things: to neutralize, control, or eliminate the offending agent, whatever that may be, to remove necrotic debris and materials, and to create an environment that's suitable for healing and repair. So those are the three things that the inflammatory response aims to do. So the 5 hallmark inflammatory response manifestations that we see are pain at the site. This is again local. Okay, I'm talking about local inflammatory response. Pain, edema, erythema, warmth, and loss of function. So each of these 5 things has a purpose. Okay, the pain is telling our brain to tell our body, hey, we have pain, do something about it, something's hurting us. The edema, the swelling, is plasma leaving the vessels that's carrying white blood cells to the area. Redness and erythema is from increased circulation, increased blood flow to the area, causing that redness, and then also the warmth. And then loss of function, which is believed to tell us as the host, the person, not to move it because it may cause more inflammation. So this is the video of the very complex cascade of events that happens in the inflammatory process. So go ahead and feel free to watch or to fast forward.
Inflammation is a critical innate defense in the war between microbial invaders and their hosts. Microorganisms trigger inflammation when they're introduced into the body and begin to grow and produce compounds that damage host cells. Resident immune cells called macrophages may wander into the infected area and engulf the invading organisms. The macrophages digest the material and in this way help clean up the infection. In response to the infection, macrophages release a number of chemicals, including those called cytokines. Cytokines are small proteins that regulate the immune response. Some diffuse into the vasculature and stimulate endothelial cells to express specific receptors called selectins. Selectin binds to carbohydrates on the surface of neutrophils, snagging the cells as they flow by in the bloodstream and slowing them down such that they roll along the endothelium. Inflammatory signals trigger these rolling neutrophils to express adhesion molecules called integrins on their surface. The integrins lock onto adhesion molecules called ICAM1 and VCAM1 on endothelial cells. The tight adhesion stops the rolling, and the neutrophils begin to stretch out along the endothelial surface. Damaged tissue cells in the area of inflammation release bradykinin, a 9-amino acid polypeptide that helps loosen the tight junctions between endothelial cells. Neutrophils can now initiate extravasation, in which they squeeze through the loosened endothelial wall and into the tissues, where they can help macrophages attack the invading microbes. Bradykinin molecules also bind to other cells of the immune system called mast cells that are in the area, causing them to release histamine. The histamine further loosens the endothelial cell junctions, allowing more fluid and cells to move out of the capillaries. Bradykinin, when it attaches to capillary cells, induces the cells to synthesize prostaglandins. Prostaglandins stimulate nerve endings, causing pain, which draws awareness to the infected area. The 5 cardinal signs of inflammation are redness, warmth, pain, swelling, and altered function at the affected site.
Okay, so as nurses, we don't need to know exactly what is going on, on the cellular level per se, but it's important to understand the purpose of the inflammatory response and the cells that are involved and the changes that happened to our vessels during this time, which we're going to go more into next. So this chart is from your textbook, and I like how it lays out what is happening after a cell is injured. All right, so pathophys map cell injury. On the left side, we have a vascular response, and on the right side, we have cellular response. So starting off with the vascular response, we're talking about blood vessels, okay, vascular vessels. So at the moment of cell injury or death, from whatever is causing it, does not matter what's causing it, there's going to be a momentary vasoconstriction. And then at that moment, there's going to be a lot of chemical mediators released. Chemical mediators, another word for chemical messengers. And a lot of cells release chemical mediators, but specifically here, white blood cells are going to be the ones releasing it. This is going to cause local vasodilation and hyperemia. Okay. Then it's going to cause increased capillary permeability and local edema. So to break that down, the local vasodilation is going to increase circulation to the area, again, locally to wherever the injury is. That hyperemia, so red blood cells are also going to come in with that increased circulation, carrying oxygen and causing that erythema or redness that we see on our skin. The increased capillary permeability, if you remember from the video, the vessels kind of open up to allow that fluid to shift from inside the vessel and to go to outside of the vessel into the tissues, carrying white blood cells to go help out, with whatever the problem is. And then that is also going to cause that edema, all of that fluid going into the tissues. Okay, so that is vascular response, part of the inflammatory response. Then we have a cellular response. So again, the cell injury is going to trigger this. We're going to have chemotaxis. So chemotaxis is from chemical mediators again, sending the message to white blood cells to come and help. So what's interesting about chemotaxis is that our vessels, the blood in our vessels run like a river. Okay, they're one direction only. But when this chemotaxis starts occurring, these white blood cells can actually go against that current and turn around to go towards where they're needed. So that's pretty interesting. So then we have margination and diapedesis of blood leukocytes. All that really means is that those white blood cells are traveling out of the blood vessel into the tissues where they're needed. Okay, so we're going to have the migration of white blood cells to this site. There are several types of white blood cells, all with a different job. So all of these guys are part of our immune response. Okay, some clean up, some engulf pathogens, and then both of these pathways will lead to the next step, which is inflammatory exudates, which we're going to talk about. Okay, so again, the vascular response, this is where those injured cells trigger vasodilation, chemical mediators, we just talked about that. So first, when exudate is produced, it's going to be serous fluid, and we'll talk about what that is. Serous fluid is fluid that leaks out of blood vessels into nearby tissues, and that fluid contains cells, dead cells, debris, protein, trash. Okay, And later it will be full of protein, mostly albumin. And again, you look at this picture, it's obviously post-op, some type of knee surgery. The leg on the right here has classic signs of inflammation. Okay, it's reddened, it's edematous, it's probably a little painful, probably doesn't have full range of motion yet. Okay, so that is classic signs of inflammation. And remember, inflammation is not the same as infection. So now let's talk a little bit about the cellular response. So we know chemotaxis is that white blood cell change of direction to site of injury, okay, specifically neutrophils and monocytes. So neutrophils are the first to arrive at the injury. They are the first responders to cell injury or cell death, okay, and they're going to engulf bacteria and other debris, foreign objects, damaged cells. They only live about 1 to 2 days. So with them, when the body has some type of infectious process, the body is going to start making more neutrophils because those are the first responders. Those are the ones that need to start doing their job the quickest. So when the body senses they're going to need more supply of neutrophils, when we look at a white blood cell count with differential, we are going to see an increased number of segmented neutrophils and bands. Okay, both of these are actually considered young neutrophils. So if we see those numbers are elevated, we call that shift to the left, which means the body is making more neutrophils in anticipation of fighting off some kind of infectious process. Okay, then we have monocytes. These guys are the second to arrive to the injury site. It's going to take a few days for them to come. They're going to kind of do cleaning. Okay, they're going to stay there for a while. They're going to get the place ready for healing. And then lymphocytes, which we will learn in our immune chapter, is related to humoral and cell-mediated immunity. So all of these cells are very important in the inflammatory response and in our immune system. So this little video is going to show you a phagocyte chasing and engulfing a pathogen. Feel free to forward after this. Okay, you can see it chasing that little pathogen there. Remember that all of our cells have these indicators on the outside, and that's how we can tell they are self cells. Okay, and then when the body doesn't recognize it, then it knows that it is a foreigner. So part of our cellular response is directly related to chemical mediators. Again, chemical mediators are just chemical messengers. So we have our complement system, C1 through C9. This is a very complex enzyme cascade in order, talking to each other, making things happen. And this is going to enhance phagocytosis, okay, which is engulfing of debris and pathogens. It's going to also increase that vascular permeability, chemotaxis, cellular lysis. So these enzymes are running the show. They're telling other cells to do things. They're sending the message, hey, we need more of this, please do this. So very important. So all of these activities here, they are very important mediators of an inflammatory response and healing. So we're going to go a little bit deeper now into chemical mediators. So prostaglandins and leukotrienes. So these guys are converted from arachidonic acid. And arachidonic acid is found inside cell membranes, inside of our cell membranes. And it doesn't ever touch anything because it's kind of locked in the cell membrane. So when a cell is injured, that arachidonic acid spills out. And when it spills out, that's how our body knows that this cell has been injured, because it knows that's only going to be spilled out if there's an injury. So at that time, it is converted into, that arachidonic acid is converted into prostaglandins, thromboxane, and leukotrienes. So prostaglandins are pro-inflammatory. That means it increases that inflammatory response that we see. Okay, they're potent vasodilators. It's going to cause increased blood flow and edema. It also sensitizes pain receptors and stimulates fever. So again, all of those things are related to prostaglandins. There are other chemical mediators, but prostaglandins are the strongest ones and the main ones in this response. Also to mention thromboxane, so this causes that brief vasoconstriction at the beginning. It also causes skin pallor at the injury site, but it has a short half-life, so this one we're not too concerned about. Then we have leukotrienes. So leukotrienes form the slow-reacting substance of anaphylaxis, which is SRSA. Okay, so it has some effect on our lungs, and that plays a big role when we have those anaphylactic reactions. So to remember, corticosteroids, NSAIDs, and ASAs inhibit steps in this pathway. So if you look at this table here, I really like it, it's from your textbook. So we have our cell membrane, okay, and here's this arachidonic acid that's in our cell membrane that when exposed, it's going to cause, you know, these things to happen. So if we give corticosteroids here, or NSAIDs or ASAs here, it's going to block the pathway. So that means it's going to decrease all of those inflammatory manifestations that we see. That is why we give steroids and NSAIDs to decrease the inflammatory response. So if you have somebody who sprained their ankle, okay, and they have the edema, they have the pain, they have the redness, are you going to give them a narcotic, or are you going to give them some ibuprofen? You're going to give them the ibuprofen because that's an NSAID. It's going to block the pathway, and it has a direct effect on the inflammatory response. Okay, so we talked about vascular, cellular. We talked a little bit about formation of exudate. We're going to go into that a little bit deeper next. And then the final stage of the inflammatory response is healing. All right, exudate, what is it? So exudate is fluid and white blood cells from vessels that move to the injury site. So it's kind of everything left over. The nature and quantity, so what it looks like, how much of it, is really dependent on how bad the injury is and which tissues are involved. So there are several different types. Okay, we have serous, which is kind of, it could be clear or yellowish tinge, it's thin. We have serosanguinous, which is like pink or diluted red. We have fibrinous, which is kind of yellow whitish. It has like fibrinous strands in it. We have hemorrhagic, which is also aka sanguinous, which is very red. Purulent, which is infection, that is like yellow, green, white, thick. And then we have catarrhal. So catarrhal is what we call the exudate that comes from our mucous membranes. So like when you have a runny nose, that stuff that's runny in your nose is called catarrhal. And also to note, exudate is corrosive. It is a biological fluid, okay, our body makes it, but it is corrosive. So when you have a wound, a big wound that has a lot of exudate, a lot of drainage, it's really important that you clean that off, that it's pulled away from the skin, and that you put a dressing on it that is absorbative to pull it away from the skin, because the longer that exudate sits on the skin, it's going to make the wound worse, deeper, bigger, all those bad things. Okay, this is just a little picture showing you the different types of exudates. Okay, and then you should be familiar with what exudates look like. So this one here looks like purulent. This is sanguinous, serosanguinous, serous. This could possibly be purulent or serosanguinous. Just depends on what the wound looks like. This is sanguinous. This is serous. This looks like it's serosanguinous, and this is purulent. All right, so we're familiar with the local manifestations of the inflammatory response, the redness, heat, pain, swelling, and loss of function. So now we're going to talk about the systemic manifestations. Okay, so now we're kind of venturing into an infectious response, okay? So malaise. Malaise is the feeling of just not feeling well. You don't really have anything specific wrong with you, you just don't feel well. That's malaise. Nausea and anorexia. So you might feel nauseous and you're just not hungry, you don't want to eat. you could have an increased pulse and respiratory rate. So this is from the rise in metabolism because of the fever, the increase in body temperature. And that fever is triggered by cytokines, those chemical messengers, and prostaglandins. We're going to see an increased white blood cell count, specifically a shift to the left. So here is a nice little table that shows you what a shift to the left is. So here is a mature neutrophil. So we call these segments here. You see they're segmented. Okay, they're named after that by the way they look. And here we have bands. So if we draw the patient's blood and then the lab looks at them under the microscope, they're going to see lots of these and lots of these immature neutrophils. So that means there's a shift to the left. This is what it will look like on your lab results. So here is normal, here is shift to the left. Again, bands and segs are elevated. So let's talk about fever. Why does it happen? So fever begins from the inflammatory response, could be an infectious process going on. It's from the release of those chemical mediators or cytokines, especially prostaglandins. It's going to cause metabolic changes in the hypothalamus. So the hypothalamus is here in our brain. Okay, that's the center that controls our thermostat, our body temperature. And this is going to trigger it to raise the thermostat. This is going to stimulate our autonomic nervous system to increase muscle tone and shivering, to reduce perspiration and peripheral blood flow. Epinephrine is going to increase our metabolic rate. So do you need to know all of these things in detail? No, but what you do need to know is that prostaglandins is what is sending the message to our brain to raise our thermostat. So you might ask, well, if this fever is part of our natural defense mechanism, our inflammatory response, then why do we want to give medication to decrease it? So we don't always give medication for a temperature. In the hospital, you'll see that there's parameters to give Tylenol. You have to wait until usually the temperature is above 100.4. Because below that, it's actually beneficial to have that increased temperature because it does kill microorganisms. It causes increased phagocytosis by neutrophils, and it causes increased proliferation of T cells, meaning T cells will divide and make more of themselves. So, and that is a good thing. Higher body temperatures also enhance the activity of interferon, which is the body's natural virus-fighting substance. So this elevated temperature is actually a good thing, but when it becomes too high, it starts to cause problems. So that's why once it hits a certain level, that's when we want to try to reduce it. Okay, so moving on to the different types of inflammation. So we're going to have acute and chronic. Acute is, of course, is going to be less, so usually lasts for maybe up to 3 weeks. That's going to include an allergic reaction, infection, trauma, a cut, frostbite, etc. Then we have chronic. So chronic is anything longer than that, weeks, months, years, a lifetime. It can be a result of cardiovascular disease, a neurological disease, autoimmune disease, anything where the body is repeatedly inflamed. Okay, usually there's a period of nothing, of remission, and then you get flare-ups, inflammation, nothing, inflammation, this cycle. So that is called chronic inflammation. Okay, so how are we going to manage this? So in the acute care setting, we're going to assess our patient. We're going to keep an eye on their vital signs. Again, we want to manage the fever. We want to determine what the cause is. We'll give antipyretics, cooling measures if necessary, antibiotics if appropriate. We don't want the fever to go above 104, definitely, because that can cause brain damage. It can cause seizures, delirium. We want to make sure the patients stay hydrated because at the higher temperature, they're going to have fluid loss from perspiration. Even if you think you're not a sweater, if you have a fever, your body is sweating, you're losing electrolytes and fluid. We want to make sure the patient maintains adequate nutrition because the body needs the tools, needs the building blocks for wound healing. And Any type of cell injury or death is a wound. Okay, that is what a wound is. Again, say you have a myocardial infarction and you have some inflammation going on in the heart, that is a wound. So those patients need proper nutrition, adequate nutrition. The body's metabolic rate is going to increase, which means their caloric needs are going to increase. And then to keep in mind, older patients that take corticosteroids may have a blunted response to fever, because that makes sense. If they're on corticosteroids for something else, it is blocking that pathway. So these patients might not get a fever, but still have a major process going on inside them. All right, so medications. So we're going to give antipyretics and anti-inflammatory. That's going to be salicylates such as aspirin and NSAIDs, antipyretic, acetaminophen, and anti-inflammatory, corticosteroids. Okay, and we also encourage the RICE method. So if you have inflammation where you want to rest it to promote wound healing, I ice it only for the first 24 hours to reduce that swelling and pain. C, compression and or immobilization. That way we don't keep causing the inflammation. And elevation. This is important to get rid of that edema, which will then help with decrease the pain, to encourage fluid return back to the heart to reduce that. Okay, this table is from your textbook. It gives you a little more detail on the role that these medications play in inflammation and healing. Again, so how do NSAIDs decrease inflammation? Okay, NSAIDs right here, they block this pathway. So these prostaglandins don't wreak havoc. Okay, moving on to the stages of healing. 3 stages. The first is those 5 hallmark signs: the warmth, edema, erythema, pain, and loss of function locally at the site. Stage 2 is going to be healing. That's when all those white blood cells go to the area to get rid of whatever's going on and to start cleaning up the site. And then the third stage of healing is the damaged tissue is replaced by scar tissue. All right, so now we're talking about the last step of the inflammation healing process, healing. So wounds are going to either heal by regeneration or repair. Regeneration is when the cells are able to replace themselves with the same type of cells, such as a paper cut. You typically don't have a scar with a paper cut. Your skin is able to regenerate those skin cells, and you never knew that you even had a paper cut. Now, on the other hand, repair is going to be the most common, and that's going to involve a scar. So this is when connective tissue replaces those lost tissues, or those cells or lost tissue. And this is going to heal by way of primary, secondary, or tertiary intention. Okay, so first we have primary intention. So if we look at this picture here, and this is typically a surgical incision where the wound edges can be perfectly approximated or perfectly lined up with each other to close without tension. So that is primary intention. When it's a nice clean wound and the wounds can approximate together, the provider can stitch it up or put staples. That is primary intention. Secondary intention is when it's not a nice clean, not a nice straight line wound, or maybe there's not enough skin to pull across so the wounds can approximate. So with secondary intention, these wounds are going to heal by granulation. So from the inside out, essentially, it's going to be left open and it'll slowly fill in, and there'll be a bigger, wider scar. So with secondary intention, you want to be careful, because when these patients are in the hospital or when they're discharged, they're going to have an open wound like this. So it's really important that you teach them aseptic techniques, wash their hands, dressing changes if applicable, and they need to follow up with their doctor to monitor that secondary intention wound healing. Then we have tertiary intention. So tertiary intention can be either primary or secondary. The difference is it's infected, it's contaminated. So wounds that have infection or necrotic material or debris, they do not heal. They cannot heal. All of that stuff has to be cleaned out before the healing process can start. So with this wound we have here contaminated, It's got to be cleaned out, whether it's debrided or we put antibiotic ointment or whatever it is. Then it'll probably turn into a secondary or primary intention after that. Either it'll be left open to heal, or if it is the right, if the wounds can approximate, then they can put in sutures or staples. So this is an example of primary intention. Looks like a surgical incision. The wound edges have nicely approximated and they're sutured closed. This is an example of secondary intention. If you see here, this looks like a punch biopsy. They literally took out this little scoop here, like an ice cream scoop. But if you see here, these edges, they're too far apart. There's not enough tissue to close them appropriately, so it's left open, and you can see it healed quite nicely. This is an example of tertiary intention. So it obviously has exudate, it's purulent, it's yellow, it's thick, it's reddened, there's probably some pain, inflammation. So this needs to be cleared up before the next step. Okay, debrided, antibiotics, something like that. All right. So moving on to wound classification. So a wound by definition is a break or opening in the skin. Before we can start treating a wound, we need to know what caused it. Was it surgical, non-surgical? Is it acute? Is it chronic? Okay, we're going to also take a look to see how deep it is, what the depth is. So it could be superficial, partial, or full thickness. And then a skin tear, which is very common in older adults because our skin, as we age, loses collagen. It becomes much more fragile, delicate, easily caused by sheer friction or even blunt force. This is a separation of skin layers, like you see in this picture. That top layer of the skin just kind of peeled back. Now, it is most common in older adults and patients who are, critically or chronically ill. However, this can also be a result of somebody maybe on a motorcycle accident, road rash. They could also have this type of skin tear. Okay, complications of healing. So lots of things can happen when the wound is trying to heal. We can have adhesions. That's what's pictured here. That's usually when you have like abdominal pelvic surgery and you separate those layers like the muscle wall. Well, when they come back together, they might create these bands of scar tissue. And when you've had multiple abdominal surgeries like that, usually every subsequent surgery becomes more and more high risk because you may encounter these bands, these adhesions. All right, we have contractures, which is pictured here. This is common with burns. Sometimes they're avoidable, sometimes they're not. Sometimes you just kind of have to let it heal and then do some type of reconstructive surgery after the fact. Dehiscence, that is pictured here. That is when a wound just kind of opens up. It doesn't want to heal. That can be from a lot of things. We'll talk about that later. We have evisceration. That is typically when an organ, usually its intestines, protrude from a wound. And you can see that here in this picture. That's an obvious evisceration. And then we have excess granulation tissue, like we see here. So this one is reddened. It looks very red, however, it's not bleeding. It can have some spotty bleeding, but it's not actively bleeding. And this is just granulation tissue that has grown in excess. You'll most commonly see that hypergranulation tissue around the G-tube site. So you can see here, it looks like it would be painful, but it really is not harmful. And usually the provider, the doctor, won't really do anything about it unless it starts to interfere with the patient's care or becomes bothersome. And they will debulk it, okay, usually with silver nitrate sticks. They can do that at the bedside, or if it's, really severe or something, they can always take it in and use a scalpel to cut it off. All right. Continuing on with complications, there can be fistula formations. That's when there is like a little pathway, a little tube that forms between two organs or between an organ and the skin. Again, we'll learn about that again later. Infection, bleeding, hypertrophic scars like this. This is large raised scars, not to be confused with keloid scars that are also raised, but these kind of bulk up like tumor-like. Okay, moving on to delayed wound healing. So what causes wounds to not heal as quickly as they should? There's a lot of different factors. So local factors include continued pressure, dehydration, trauma and edema, infection, necrosis, patient who's incontinent, always wet. That maceration can lead to delayed wound healing, lack of oxygen delivery to tissues. So anything that causes lack of oxygen, like anemia. Okay, systemic factors, older age, obesities, chronic diseases such as diabetes, anemia, malnutrition, anything, again, that compromises the delivery of oxygen, vascular insufficiency, smoking, stress, poor health, mental deterioration. Okay, so review table 11.8 for more details. And then for your knowledge, the team for wounds include a wound ostomy continence nurse, RN, LVN, dietitian, because nutrition is important, physician practitioners, and always include patient and family members, okay, because when these patients go home, they need to be able to continue the plan of care. Okay, this table is from your book, 11.8, very nicely describes the different factors in delayed wound healing. All right, moving on to wound care. So the purpose of wound care is to keep it clean and to keep it protected. We want to clean the debris or the dirt or infection because that's the only way the wounds can have a chance to heal. The type of wound management will vary from facility to facility. However, the basics are the same. The concepts are the same, and it really depends on what kind of wound it is, how big is it, the characteristics, and what phase of healing the wound is in. All right, contaminated wounds. When we say contaminated, we are talking about debris, necrotic material, infection. So again, these must be considered, quote, clean before healing can occur. They will probably need some type of debridement. Review table 11.10 on the different types of debridement. Absorbative dressings. So absorbative dressings, again, because remember that exudate is corrosive if left on the skin, so those absorbative dressings will absorb that and bring it away from the skin. And then hydrocolloid dressings are also used for moderate drainage. And then, yes, review 11.9, very important table. Okay, so clean wounds. So wounds that don't have any infection, debris, or necrotic material. They will be closed with stitches, steri-strips, staples. They may need topical antimicrobials. They may have a drain involved to help get rid of some of that extra fluid, that exudate. Just depends. We have negative pressure wound therapy or a wound vac. There's only a couple different types of brands out there, so it's very likely that you've seen this one here pictured. So this is suction, and it's going to remove fluid, exudate, and bacteria from the wound bed. So number one, this wound has to be infection-free before starting a wound vac, okay? And because it has suction, we're going to have to monitor lab values. So we want to make sure protein levels are okay, because remember that fluid, that exudate, has a lot of protein, has a lot of albumin in it. So we want to monitor those levels. We also want to monitor fluid and electrolyte imbalance in general, and coagulation studies, because if a patient has prolonged bleeding times, so maybe they're hypercoagulated and they're hooked up to suction and they have this open wound, you may come in the room and find this whole canister full of blood. So we don't want that to happen. So we want to keep an eye on those labs to make sure that they're not at risk for that. Okay, then this is a hyperbaric oxygen therapy chamber. So this is very helpful. It creates an increased atmospheric pressure of oxygen, which is really nice. It can be given like by body part if they have the machine for that, but usually it's like a whole machine and it's given systemically. So patients can have, sessions a couple times a week with this, and it really helps, very beneficial with wound healing. However, not all facilities have these chambers, so not everyone has access. All right, management. So how do we assess a wound? How do we document this? So with the wounds, we're looking at the location, the size, the depth, undermining, tunneling, wound margins, and wound base. Hopefully where you work, you have a wound nurse, a wound treatment nurse, and that nurse will take care of it. But you as the RN, you should know how to do this. Okay, so remember, you need to assess every new patient that you see from head to toe, and on every shift, you should be looking at their skin. You're going to follow your facility's protocol and take pictures and measure wounds. Usually it's weekly. All right, so we're going to use a clock. Okay, so this is the head. Okay, it's really important that we use the same system because you want to make sure your measurements are the same as another nurse's orientation wise. So say you're measuring this wound, you get your measurements. Remember, it's always in centimeters. And then say the nurse measures it from a different direction, and so her numbers are completely off. How can you tell? So we always use the standard. Okay, the 12 o'clock is going to be at the head, and the toe is going to be the feet. And then when we use the clock to determine tunneling and undermining, which we'll talk about, you know, you say it as a time. So what time is it? Let's see, 7 o'clock, tunneling, something like that. Okay, so how do we care for these wounds? There is a drug therapy called becaplirmin. Very expensive. It's from human platelets. It's used on foot ulcers, usually related to diabetics. Nutritional therapy, again, nutrition is so important because our body gets the healing components from what we eat, from our nutrition. So these patients should be hydrated. They should have a diet high in protein, carbs, moderate fat. They should be on vitamins A, B, and C. So you'll see when you're in the hospital at your clinicals and you have a patient with a wound, they should have vitamins on their mark. 99.9 they're going to have vitamins, and if they don't have vitamins, that's something that you would tell the doctor, hey, this patient has a big old wound, they would benefit from vitamins. All right, if the patient isn't eating well, then they may be a candidate for enteral, which is tube feedings, or parenteral feedings if needed, like TPN. And then with any kind of broken skin, open wound, we need to make sure we prevent infection as much as possible. So aseptic techniques, not only for the nurse, but for the patient and the family. So lots of hand washing. We want to keep the environment free from contaminated items. Don't keep that urinal on top of their table, that kind of stuff. Some patients may need prophylactic antibiotics. Not everyone, it's just case by case. And then if there is a suspicion that the wound is infected, then you as the nurse will need to get a culture, a CNS, culture and sensitivity swab. With that, we use Levine's technique. Okay, so say you have a wound, it's an ugly wound, it's got lots of exudate here. So if you were to get your cotton tip swab and, you know, come in here and get all this goop on it, it's not going to be real. Okay, it's not going to have a realistic sample of the organism that's living there. It's going to be way crazy because of course that's infected. That's all that goopy stuff. So Levine's technique is you need to clean a 1 centimeter by 1 centimeter of that goop off. You need to clean it off. You can use any non-cytotoxic solution, and you clean it off, and then once you have this little area cleaned off, that's when you apply your cotton tip. You press down to get some fluid from the wound bed, and that will give you a more realistic view of the colonies living on the wound. Okay, and then remember, you have to get your cultures before you start antibiotics. Okay, so along with wound management, changing dressings, we also have to remember of the psychological implications. So again, we always think of the old patient, confused patient, doesn't, you know, the bedbound patient, but we also have patients that are alert oriented ×4, walkie-talkies, like me and you. You know, there can be fear of scars or disfigurement, especially if it's like a burn patient. There might be drainage and odor, so they might be self-conscious about it. And when you're in the room with these patients, you want to be very self-aware of your facial expressions, what you're saying. You don't want to make an ugly face and make the patient feel uncomfortable. And patient teaching. So wound care, dressing changes, aseptic technique to prevent infection. They should be getting rest. They should stay hydrated, nutrition, minimize stress. They should be aware of the signs and symptoms of infection, when to call their doctor, and of course, if they're on antibiotics, they should complete the full regimen to avoid resistant organisms. So now we're going to talk about pressure injuries. So pressure injuries, it is impaired skin integrity due to unrelieved pressure. Very simple. A patient is in the same spot for a really long time, there's going to be skin breakdown, especially on those bony prominences. This can also be related to a medical device. It can be a result from friction and shear, which we'll talk about. And excessive moisture increases risk for skin breakdown, like incontinence and perspiration. So take a look at this slide. This shows the major pressure points on our skeleton, and some of them are obvious, but some you may not think as being pressure points. So if you take a look here, if a patient is wheelchair bound, the shoulder blade and that coccyx bone there, the heel and the ball of the foot are at risk. And then if you see here, if the patient's laying on their side, this little spot in between the knees. So these are all spots we have to look at when we're doing our head-to-toe assessment. If a patient has a cast on, they're also at risk for developing a pressure injury. Maybe when they put the cast on, they put it on too tight and it rubs, on the elbow or the wrist. Or maybe the patient developed edema after they put the cast on, so it's going to put that extra pressure. So all of these things we need to keep in mind. So these are the pictures that show very preventable pressure injuries. So nowadays hospitals are really big on preventing them. They have a lot of devices and tools to help prevent these, and it is part of the 2022 National Patient Safety Goals for hospitals on preventing pressure injuries. So when a patient develops a pressure injury in the hospital, it's called a HAPI, hospital-acquired pressure injury. We do not want those. So do your due diligence, be the prudent nurse, and check your patient's skin from head to toe. Never take word for word that the previous nurse checked, oh, skin intact. No, always look with your own eyes. All right, so this picture here is a child with an NG tube. You can see here, this is a pressure injury. And it looks like this side of the nair is also going to get one too because it's not free floating. So again, preventable. This one looks like it may have been some type of oxygen delivery mask, probably a BiPAP that has to fit tightly to the face. This one here looks like it's from tubing, likely maybe a nasal cannula. Here under the trach plate, very common area because it tends to be moist and wet. It can develop a little pressure injury. And then this one, you can see this little device here is from a Foley catheter. Got lodged in between the abdominal skin folds and created skin breakdown. So this can happen over a very, very short amount of time. And although not every single pressure injury is preventable, because sometimes you're going to have those patients who are in ICU who maybe are very unstable, we cannot turn them because they're hemodynamically unstable. And remember, those patients are ill, okay? They're critically ill. They may have issues with oxygen circulation, right? They may have inadequate nutrition. So all of those things combined, sometimes it's very, very difficult to prevent a pressure injury on those type of patients. So this slide just shows how much money it costs to take care of a pressure injury when it is acquired in the hospital. So it is billions and billions of dollars a year, and there's many, many lawsuits that come from it. Well, many patients die as a result of pressure injuries. So it's really important that we do our best to prevent these from happening. Okay, so friction and shear, what is it? So you can see here in the picture, what basically is happening is, the skin is going one way, the body's going another, and it causes these little micro tears underneath in the subcutaneous tissue, and it causes decreased oxygen supply. So that's where that pressure injury comes from. So what are the risk factors? So there's a lot of risk factors. We have age, we have anemia, contractures, diabetes, elevated body temperature, and so on. You can read through these. So all of these are risk factors for pressure injuries. Okay, so let's go through the stages. We have 1, 2, 3, 4, and then the stages, of course, are based on depth. Okay, please review table 11.13 on assessing patients with dark skin. It's a very small table, but it gives you insight because when we assess these wounds, especially stage 1, we look for blanching of the skin. And if the patient already has dark skin, we're going to need another approach to assess that. So please review table 11.13. All right, so stage 1. So stage 1 is intact skin, okay, intact. So you see here, there is no opening in the skin. It is intact. However, it is red. And when you push your finger down on there, it does not blanch. So it does not turn white. That is a stage 1. Stage 2, not intact. Okay, so stage 1, intact. As soon as it's not intact, it becomes at least a stage 2. You can see here. So here you're going to have a partial loss of the dermis. Okay, you see it's already past the epidermis down into the dermis. And if a patient has a blister, okay, that is a stage 2. Even if the blister has not ruptured, it is still a stage 2. Once it ruptures, still a stage 2. All right, so stage 3, definitely the skin is not intact. There's going to be full loss of skin tissue. So the epidermis, the dermis is gone. Okay, and then we're going to see some subcutaneous tissue, some fatty tissue. The wounds may roll away from the wound bed also. Not always, but that could also be a sign. Then we have stage 4. So stage 4 is full loss of skin tissue. So no epidermis, no dermis, no subcutaneous tissue. This is going to be all the way down to the muscle, tendon, ligaments, or bone. Okay, you can see here in this picture, this is the coccyx bone. This is negligence, 100%. Then we have unstageable. So this is when we have necrotic material, eschar, blackened, or this yellowy slough on top, and we cannot see the wound bed. So if we cannot see the wound bed, we cannot tell what type of what stage the pressure injury is at. So this is obviously not a stage 1. It's probably not a stage 2. It's probably at least a stage 3, probably a stage 4. But we cannot say that because we cannot see the wound bed. So first, we have to clean all that out. That needs to be debrided and cleaned and not contaminated in order for us to call it something. Then we have a deep tissue pressure injury. So this is when the skin is intact, but it is this purplish color, okay, keyword purplish. And this is when the subcutaneous tissue is injured, okay, and then when you push on it, it feels spongy, okay. So this is a DTPI, deep tissue pressure injury. This is tunneling and undermining. So tunneling is when you literally have little tunnels, little tracks, okay, it can be anywhere in the wound. Undermining is when it widens underneath the skin. So you can see undermining is right here below the skin. So really when we measure this wound right here, we're measuring from like here all the way to here. That's how we measure. That's why this line is drawn here, because that's the real wound bed, because we have undermining. All right, an 86-year-old female patient is immobile and is in the right lateral recumbent position. As the nurse, you know that which sites below are most at risk for pressure injury in this position. Select all that apply. So with this one, you're going to have to picture the patient in the right lateral recumbent position. Okay, and then just pick all the ones you feel. So definitely the ear, the hip, the shoulders. Okay, let's see. Here we go. You can look at all the stars here. All right, moving on. Okay, so how do we know if it's infected? Well, we're going to have a high WBC count. We're going to have a fever. That wound can get bigger. It can get a foul odor. It can have more drainage. It can develop necrotic tissue in the form of eschar, or you'll see some blackened areas. It can be indurated, warm, painful, and if left untreated can lead to cellulitis, chronic infection, osteomyelitis, that's when it travels to the bone, and it can lead to death, as we are aware of. So we are going to follow prescribed wound orders, okay? And we want to pre-medicate these patients 30 minutes prior if they're going to have pain, if it's a big wound. We're going to irrigate the wound, avoiding cytotoxic solutions, okay? We want to keep the wound bed moist. These type of wounds, they like to be moist. We don't want to keep it dry. They are going to need debridement if they have all this stuff going on. So we can use mechanical debridement, which is a wet to dry dressing. That's kind of an old practice. We don't do that too much, but your textbook still mentions it, so I'm mentioning it. We have chemical debridement like Santil. Santil is like a gel and ointment. It's enzymes, and it kind of just eats away at that necrotic material. This is a picture of that. This is good on patients who are not a good candidate for surgical debridement. Doctors can also use a form of debridement with medihoney or silver nitrate sticks. Surgical debridement might be necessary. That can be done at the bedside or in the operating room. Once the wound is clean, we can definitely use wound vac or hyperbaric therapy to facilitate that. So you as a nurse need to do a head-to-toe skin assessment when you get a new patient, and every shift. You're going to document the stage, location, size, color, drainage, odor. You're going to follow your facility's protocol with taking pictures and documentation. If you suspect there is an infection, then we'll need to get wound cultures. Definitely a wound care nurse consult. That's what they're there for, so utilize them. We want to use a standardized tool to monitor for the risk for pressure injury, such as a Braden scale. Every facility has some form of standardized way to assess for this. 9 times out of 10, they use the Braden scale. And you'll see an example of that on the next page. So this Braden scale is pretty straightforward. There's different categories. It's based on moisture, sensory perception, activity, nutrition, and so on. You get a score. Okay, the lower the score, the higher risk for skin breakdown. Nursing management. So what do we need to know? We need to identify those patients at risk, okay, like using the Braden scale. We want to keep them as clean and dry as possible. There's lots of products. Again, every facility has their own products, so use them. We have moisture barrier creams. We have exterior urinary collection devices such as a Puric and condom cap. I have an example on the next slide. We want to keep everybody's linen clean and free from wrinkles. If they're unable to turn themselves, we want to make sure they reposition every 2 hours. We don't want to do activities that cause that friction and shear. We have devices, special air mattresses, heel protectors, boots, and wedges. The different facilities I've worked at, the heel protectors, we just follow your facility. Sometimes they do not use them, sometimes they do, so you just follow your facility. If a patient has a medical device, such as some type of brace on their legs, maybe they had an orthopedic surgery, you need to look under that device every shift. Even if the order says do not remove, that doesn't mean you cannot check the skin integrity. Under the trach plate, if they have any type of line or tubing, a Foley catheter, suprapubic catheter, nasal cannula, a face mask, anything, you have to make sure you check those for skin breakdown. And if the patient's in the hospital, make sure they have a dietitian consult. That's what they're there for. They can customize their nutrition needs to make sure they're on that high caloric diet. They have high protein. If they get vitamins, they can also recommend supplements like Ensure and Juven. So really important. Okay, this is what a Puric looks like for those of you who have never seen one. And then we have our condom cap. So the Puric has a canister hooked up to suction. This tube here is hooked up to this little device here. This is plastic. Blue part is plastic. This is fabric. So you turn on the suction. You put this right between the labia, sitting on top of the urethra. And when the patient voids, it gets suction into the canister. For the condom cap, you have this little plastic device here. It has adhesive inside already. This part looks like a condom. It's applied just like a condom, but it has this little tube here that hooks up to a urinary collection bag. These are very effective, again, very effective until they're not effective, okay? All right, so a question, a nurse is caring for a patient who has a stage 3 pressure ulcer. The nurse should recognize that which of the following laboratory findings will affect wound healing. We have albumin, we have hemoglobin, WBC, and PTT. And albumin. Albumin level is a good indicator of nutritional status, okay? Not only that, but if a patient has a wound vac, we also want to monitor albumin because they can be losing that protein through that exudate being suctioned. All right, and that concludes this chapter.